Hello everyone, my name is Matthias Walter. I'm very grateful for ICS giving us the opportunity to present our data today. These are our disclosures. Management of autonomic dysfunction is of high priority for individuals with spinal cord injury. Autonomic dysfunction is a potentially life-threatening condition following SCI and places a tremendous burden on individuals with spinal cord injury. A recent study suggested that tachycardia may be commonly occur with AD. However, this finding contradicts the previous understanding of a parasympathetically mediated heart rate decrease as an attempt to lower elevated blood pressure. Considering the aforementioned, our aim was to characterize AD-associated heart rate changes during penile vibrostimulation and urodynamic studies in adults with chronic spinal cord injury. We performed a secondary data analysis from two previous trials, one clinical trial on urodynamics and one feasibility pilot study on PVS. We included individuals with chronic spinal cord injury at the spinal segment T6 and above, who had complete continuous cardiovascular monitoring data sets. Overall, we assessed 21 individuals at median age of 41 years and a median post-injury of 18 years. All assessments were performed in our specialized SCI outpatient clinic, which is integrated in our university-based laboratory. PVS was applied using a handheld vibrator to induce ejaculation. We used a frequency between 70 and 100 Hz with an amplitude of 1.0 to 3.5 millimeters. Roughly stimulated for 3 minutes, and we performed this repeatedly until the participant ejaculated or until 5 stimulation cycles were completed. Urodynamics were performed in accordance with the International Cardio Society Good Urodynamic Practices. Heart rate and beat-to-beat blood pressure were non-invasively recorded continuously for 10 minutes before and during urodynamics or PVS. Recordings with a systolic blood pressure increase over 20 millimeters mercury from baseline in response to PVS and urodynamics were used to characterize assessment-specific AD-associated heart rate changes. For each AD episode during PVS and UDS, AD threshold and AD peak were identified. Then all corresponding heart rates were identified to calculate change in the heart rate from baseline. This slide highlights the results from our PVS trial. On average, we performed 3 penile vibrostimulators per individual, and we recorded 37 AD episodes with at least 1 AD episode per individual. At AD threshold, heart rate increased at 51% and decreased at 41%. Bradycardia was detected in 43%, and normal cardio was recorded in 57%. At AD threshold, we didn't find any tachycardia. At AD peak, we saw a mean increase in systolic blood pressure by 67 millimeters mercury with an associated median heart rate decrease of 10 beats per minute. Bradycardia was seen in 65% of the participants and normal cardio was present in 35%. Again, no tachycardia was discovered. At the moment of ejaculation during PVS, we saw a median increase of almost 100 millimeters mercury with an associated median heart rate drop of 20 beats per minute. This slide highlights the findings during urodynamics. We performed 1 urodynamic per individual and were able to detect AD in each individual. At AD threshold, we saw heart rate increases by 40% and the heart rate decrease in 40% as well. In 20%, heart rate did not change. Bradycardia was discovered in 30%, while normal cardio was present in 70%. At AD peak, median increase in systolic blood pressure was 53 millimeters mercury with an associated median heart rate drop of -2 BPM, where cardia was present in 50%, while normal cardia was present in 40%. Only one male individual with a T3 ASA with spinal cord injury had a slight tachycardia with 102 beats per minute. During Urodynamics, individuals presented with clinical signs of AD as well as non-classical AD signs and symptoms as outlined in this table. Swelling, flushing were the most common AD symptoms, while unspecified blood sensation, unspecified spasm, abdominal pressure, and the sore lower back were noticed as non-classic AD signs and symptoms. In conclusion, our study indicates that AD-associated heart rate changes during PVS and UDS are related to the magnitude of systolic blood pressure increase. At AD threshold, frequencies of heart rate increase and decrease were almost balanced. At AD peak, mainly bradycardia was observed during PVS and UDS. PVS is a more potent trigger as AD compared to UDS, and we think that continuous non-risk cardiovascular monitoring may help to indicate severe episodes of AD during PVS and UDS. And with that, I would like to conclude my presentation. Again, thank you, ICS, for giving us the opportunity to present our data. We are very grateful for funding support by all these agencies. And we have a preprint available for anyone who wants to know more about this study. And if you have any questions, feel free to send me an email. Thank you.